Ladies and gentlemen, as a courtesy to our speakers and other attendees, please take this time to silence your mobile phones. Ladies and gentlemen, welcome to the 8th IAS Conference on HIV Pathogenesis Treatment and Prevention opening session. Please welcome to the stage this evening's Master of Ceremonies, Gloria Makarenko of the Canadian Broadcasting Corporation.
Hello, ladies and gentlemen, distinguished guests. It is my sincere pleasure to welcome all of you to Vancouver for such an important event. Mesdames et messieurs, bienvenue à Vancouver. It is an honor for me to be with you here today. I have worked as a journalist in this city for 30 years, and I have witnessed firsthand the devastating effects of the HIV epidemic, and I must say that the day-to-day work that you do, all of you in this room, from all over the globe, do to help end the HIV/AIDS epidemic is inspiring. I have seen firsthand with my involvement with the Dr. Peters Centre here in Vancouver. I think it is reassuring that despite so much conflict all around the world, there are still so many people willing and wanting to make the planet a better place. So my thanks to all of you. And what a role British Columbia has played here too in Canada. Dr. Montaner and your team, take a big bow, please. You have made us proud, and I can imagine that this event is of enormous pride to you as well. I would now like to welcome Elder Larry Grant to the stage to give us his opening prayer, and welcome to the ancestral and traditional Aboriginal territories of the Coast Salish people that we are on today. Larry is born and raised in Musqueam traditional territory. After 4 decades as a tradesman, he enrolled in the First Nations language program, which awoke his memory of the embedded value of his native language. So right now he's assisting in revitalizing and teaching introductory courses in his language at the University of British Columbia. Ladies and gentlemen, please welcome Larry Grant.
Thank you for that introduction. Good evening, everyone. All of our distinguished guests from around the world and everyone that's here that is working diligently on this concern of ours in this world. Siyam nasiyaya ayaslak gunaskui I tenitin kumasquiam. Tlaak sesiwenes kepalano I hultimoto kus hilakstok to huinas imignetten shui te Dus alles tamoker kumasquiam. Zet is something neat to swallow. It's the atala. I tap ewas siyam nasiyaya tamokalap kus society. I sleek was so anak muk to mistake to need to tamoker to smoke tamok high tapaka siyam nasiyaya. Just want to say thank you and welcome to all of our distinguished guests here. Ayaslak is my Musqueam name, Larry Grant is my English name, and I am the great-great-great-grandnephew of our warrior Kepalano, who was here to greet the first visitor to arrive on our lands, the Spanish under Captain Narvaez and the English under Captain George Vancouver. Our people have lived on this land since the last ice age about 10,000 years ago, moving down on the delta as it's being formed. And we have lived in our community of Musqueam continuously for 4,000 years. And Canada is going to celebrate 150 years in a year or two. So we are the first peoples of this land. Maybe not as long as the Kennebec man has been here 32,000 years ago, but we have been the people that were here since the last ice age. And I'm really, really happy and privileged to be here this evening to give the welcome to Central Coast Salish Territory on behalf of the Hunkaminam-speaking Musqueam people and our relatives from Squamish and our relatives from Tsleil-Waututh who live on the North Shore at this time. And I raise my hands in welcome and thanks to all of you that are here on the traditional, ancestral, unceded lands of the Hunkaminam-speaking Musqueam people, the occupied lands of the Hunkaminam-speaking Musqueam people. And I want to say welcome and thanks to everyone that is working on this solution to help our people, the ones that have HIV and the ones that have AIDS. It is so important to all of us that we work together to help the world in eradicating this disease that we have, that it's something that I think as world leaders that we need to do. And I want to say, Haitsepka Siamna Shea Tsiatala Tishwalap Hui Naman Tenakunan. Haitsepka. Thank you. Thank you so much. Thank you.
Larry, thank you very, very much. I just love it when he speaks in his native language. It just takes us somewhere else entirely. It is now my great pleasure to welcome Chris Beyer, the current president of the International AIDS Society and international chair of this conference. Professor Beyer is professor of epidemiology, international health, and health behavior and society at the Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland. He serves as director of Johns Hopkins training program in HIV epidemiology and prevention science, and as founding director of the Center for Public Health and Human Rights. He is the associate director of the Johns Hopkins Center for AIDS Research, CFAR, and the University Center for Global Health. He currently serves as a member of the MSN working group of the HIV Prevention Trials Network. So as director of the Johns Hopkins Fogarty AITRP program, Professor Beyer provided fellowships for more than 1,400 international scholars in HIV/AIDS prevention, research, and treatment. He has done extensive research in the epidemiology of HIV in Thailand, Burma, China, India, and across Southeast Asia, in Russia and Kazakhstan, in Malawi, South Africa, and the US, and the list goes on. So this is Dr. Beyer's first conference as IAS president. I think you will all agree with me that with credentials like his, that both the conference and the IAS are in fine hands. Ladies and gentlemen, please welcome Chris Beyer.
Good evening, ladies and gentlemen, friends and colleagues. Welcome to Vancouver and to the 8th International AIDS Society Conference on HIV Pathogenesis, Treatment and Prevention, IAS 2015. This is the largest open HIV scientific conference in the world, and I'd like to acknowledge that we are here together on the ancestral lands and traditional home of the Aboriginal territories of the Coast Salish people. More than 6,000 of us from 125 countries are gathered here in this wonderful city of Vancouver, a city that's a true public health leader, led in no small measure by my co-chair and friend, Julio Montaner. Vancouver holds a special place in the hearts of all of us in HIV/AIDS because it was here at the International AIDS Conference in 1996 that the HIV treatment era truly began. And so it's only fitting that we should be here to celebrate together the extraordinary achievement of having 15 million people on antiviral therapy in 2015. Yeah. While we celebrate that unique moment together this week, it's difficult not to also remember those of us who helped make these achievements happen, but who are not here with us tonight. It's just a year since the terrorist attack on flight MH17 needlessly ended so many lives, including 6 very special people from our own community. At this conference, we will inaugurate the Yop Lang Memorial Lecture, which will be a permanent part of the IAS conferences and a fitting tribute to his legacy. Dr. Prapan Panupak, Yop's longtime colleague at the Thai Red Cross, will deliver that inaugural address. With our partners at the ANRS, we have renamed our annual prizes, which recognize the highest scoring abstracts from young investigators in each track at the conferences. Moving forward, these will be known as the Yop Lang and Jacqueline Van Tongeren Young Investigator Awards, fitting tribute to their impact and the impact that their very special partnership had on all of us. There are many people to thank, including my co-chair, Julio, who you're going to hear from soon, and his extraordinary team at the Center of Excellence at the University of British Columbia. Let me also thank the members of the Conference Coordinating Committee, our highly dedicated track co-chairs, the members of the track committees, and all of you who reviewed abstracts. Special thanks to our amazing IAS Secretariat team, led by our Executive Director, Owen Ryan, Senior Conference Manager, Megan Warren. They've done really remarkable behind-the-scenes work in putting together the truly outstanding program we're all going to share. IAS 2015 looks to be another Vancouver landmark. This conference's scientific abstracts are the most competitive we've ever had, with the highest review scores for any IAS conference. Competition was so close and the late breakers so important that we had to expand the program by about 20% in the last few months. And over 2,700 submissions, just 4.5 were accepted for oral presentation and 2.5 for oral poster discussions. 52% of abstract submissions had women as first authors. So men in the audience, you got to step up. And we had as many submissions from Africa, just about, as we had from North America. So that really speaks to the international nature of this. Yes, indeed. The quality and the import of this science is due to all of your hard work. But it's also due to the fact that we're living through an unparalleled time in HIV science across prevention, treatment, cure research, and vaccines. Having reached 15 million people on treatment in 2015, as you'll hear from my friend Michel Sidibe, truly is an astounding moment, and it is really a milestone in human health. And yet, we are still seeing unacceptable, sometimes rising rates of new infection in too many countries and in too many communities. Among key populations, from young gay and bisexual men throughout the world, to young women and girls in sub-Saharan Africa, to people who inject drugs in Eastern Europe and Central Asia, many of whom could benefit from antiretroviral-based prevention, and all of whom are going to need human rights protections if they're going to realize those benefits. Yet 4 years after the results of the IPREX trial and 3 years after FDA approval in the United States, we have just one country implementing PrEP. For most people worldwide who might benefit from this new prevention tool, the PrEP access era has not yet begun. We also need additional preventive options, and of course we all know we need a vaccine and we need a cure. We have at this point just one man who's been cured of chronic HIV infection, and we've had one vaccine trial show any evidence for efficacy. So new science and continued investment in research is a key to living in this world without AIDS that we all want to see, and we need to make that case. So I would ask us as a community to draw a line in the sand here in Vancouver. Let's let this be the conference where the question when to start ART stops being a scientific question and starts being a matter of implementation, financing, and political will. Let's commit to treatment access for the 22 million of our brothers and sisters living with HIV who are not on ART. And let's work together to ensure that the research support we need for the next generation of HIV researchers, the young researchers, is there to carry us forward. The HIV community is a special one. We're global, we're passionate, we're smart, we care about the most vulnerable people among us, and we have a long struggle ahead to try and control the pandemic. But if anyone can do it, we can. You can. And I want to thank all of you for the work that you do every day. It's a profound honor to serve you all as IAS president, and a relatively brief one. The leaders of your organization serve for just 2 years. And for those of you who are IAS members, thank you. We hope you've noticed the changes underway at the IAS since the Melbourne conference, and I'd like to ask for your personal engagement and support as we go forward. Let me introduce to you our Executive Director of the IAS, Owen Ryan. Owen's been with us for just a year, but has really done an extraordinary job in taking us forward. Please welcome Owen Ryan.
Thank you, Chris. Thank you, ladies and gentlemen. I am Owen Ryan, the Executive Director of the International AIDS Society. I have to say, it's a real privilege to be here serving the IAS. I would be lying if I didn't also say this is a little bit intimidating. I got started in HIV when I was 18, working at a small nonprofit in Washington, D.C., so to be here standing in front of all of you, all of the leading thinkers in our field, well, I have a mom in New Jersey who is very proud tonight, so thank you very much for that. So I want to talk a little bit about, as Chris alluded to, some of the changes that have been going on at the IAS, but before I do that, I would like to thank our governing council. This is a group of people who give of their time freely to ensure that the IAS is a success, and we are greatly appreciative of their work, so thank you. I would also like to thank 4 people in particular: our president, Chris Beyer, our president-elect, Linda Gale Becker, our treasurer, Anton Pozniak, and our immediate past president, Françoise Barry-Sinoussi, when she is not commenting on how terrible my French is, have all given a tremendous amount of their time to ensuring that I could be here with you tonight. So as I said, I want to talk a little bit about the change that's ongoing. When I started a year ago, I reached out to many of you to ask you about your experiences with the IAS. Unsurprisingly, many of you were very forthcoming about the joys and the frustrations of working with the IAS, and there was one really common theme through all of that. Many of you felt that the IAS has been an essential part of getting us from where we were in the AIDS response to where we are today. However, you felt like if we were going to achieve our ambitions, if we really are going to reach these targets, the IAS needed to be something different. Most specifically, you felt that membership needed to be more than a box you tick on your way to a conference. I get that. I get it intuitively. I have been an IAS member since 2008. I understand the desire to make sure that your individual contributions to this field add up to a greater whole, that your membership has agency, that you feel like you're part of something that has real movement. I believe strongly that the IAS is the leading voice for the implementation of the science that you all work so hard to study. I believe strongly that our individual efforts can add up to a greater whole, that we really can have that agency. But I can't do it all by myself. I can change how we do business in Geneva, and trust me, we have changed a lot. But I can't decide where this movement is going without you. So if you're someone who feels like the voice of HIV is becoming diffuse, that a crowded global health landscape is making it unclear exactly what we're saying and what we're trying to say and what we're trying to accomplish, then I'm asking you to engage tonight. And this is in a very serious way. And there are 2 ways I would like you to do that. First, I'd love for you to send me an email. I mean that honestly. So you can send an email to Owen at IASsociety.org. I also want you to go online and fill out our survey. I know you are asked to fill out a lot of surveys, and this is not just a simple satisfaction survey. We are in the process of developing our 2016 to 2020 strategy right now, and your input and feedback on where you want us to go and what you want us to do in a very blunt way is absolutely going to form the building blocks of how we do that. So again, I really feel like our moment is now. I feel like we can make the IAS what we want it to be, but you have to engage. Thank you.
It's now my great pleasure to introduce my co-chair for IAS 2015, Professor Julio Montaner of the Center of Excellence in HIV Research at the University of British Columbia. Julio, of course, is a past president of the IAS, and he's known to us all as an outstanding clinician, investigator, and a leading thinker in our field. But I think more importantly, he's known as a tireless advocate for the right for all people living with HIV to have access to therapy. Please join me in welcoming Julio Montaner.
Thank you, Chris, for your kind words towards our beloved city of Vancouver. It has been a pleasure to work together with you, the organizing committees, the multiple partners, as well as the highly capable IAS, BC Center for Excellence in HIV/AIDS, and UBC staff to bring together the best science has to offer to IAS 2015 in Vancouver. I want to thank you all for your great effort and commitment. Allow me also to take a moment to thank Premier Chrissy Clark, who couldn't be here today with us, for the initial $500,000 that we needed to put together the Vancouver bid for this conference. Once again, she came to the table to do the right thing for us. Dear colleagues, distinguished guests, and friends, I want to acknowledge we are on the ancestral and traditional Aboriginal territories of the Coast Salish. Thank you, Elder Grant, for reminding us of this and for your prayer. As you see, I am wearing a First Nations blanket presented to me last week by Ken Clement and the Canadian Aboriginal AIDS Network in celebration of our collective efforts in the fight against HIV. I was deeply moved by this gift, and I will treasure it for a long time to come. If I can apologize for a moment, it's a little bit warm, so I'm going to take the blanket off. Thank you. I welcome you all to my adopted home of Vancouver and the province of British Columbia, a jurisdiction, as Chris so aptly described, at the forefront in the fight against HIV and AIDS. It's almost 2 decades since we last met in Vancouver at the 1996 International AIDS Conference. And isn't it extraordinary to look back and see how far we have come together? It was then that we embraced triple drug therapy, later known as HART, as the new standard of care. It was a pivotal moment in the history of the pandemic. HART would go on to save millions of lives in the north and in the south of the world. Flash forward to today, we have over 15 million people on treatment before the end of 2015, something I believe will go down in history as one of the defining achievements of this century, a global health milestone. So many said it couldn't be done, and Michelle says we're going to do it, and yes, we did it. But that was only the beginning. By the year 2000, we had an inkling that antiretroviral therapy would not only be life-saving, it would be markedly able to reduce infectiousness and thus prevent HIV transmission. The notion of treatment as prevention was born. Treatment prevents disease progression to AIDS and premature death, and secondarily, for no additional cost or infrastructure, it prevents HIV transmission. IAS 2011 in Rome brought us the compelling results of HPTN 052, which confirmed that antiretroviral therapy reduced HIV transmission by over 95%. The evidence was irrefutable, and while guidelines were already moving to embrace immediate therapy after an HIV-positive test, we were challenged by naysayers again and again and again. And that's where IAS 2015 comes into the picture. This week, we will finally complete the definitive body of irrefutable evidence that will make treatment as prevention the new global standard of care. The final set of results from HPTN 052 will confirm the durability of the preventive benefit of antiretroviral treatment on HIV transmission. Implementation studies will confirm that treatment as prevention works just as well in Vancouver, in San Francisco, in Rwanda, in KwaZulu-Natal, and wherever else it has been tried. And also, the results from the Temprano and START trials will conclusively and definitively show that immediate access to antiretroviral treatment, regardless of CD4 count, is life-saving. Period. End of the discussion. Treatment as prevention is it. Over a year ago, UNAIDS, under the leadership of Michelle, in a bold and courageous move, and rightly anticipating these developments, embraced the treatment as prevention strategy with the unveiling of the 90-90-90 target. You will hear in detail about this target and the strategy from Michelle shortly. Today, my friends, we have a unique opportunity to build on our scientific database and begin to write the final chapter of the AIDS pandemic. Health agencies, funders, small governments, large governments, presidents, prime ministers, although not the Prime Minister of Canada, have rallied quickly to embrace a strategy. Treatment as prevention is the strategy, and the 90-90-90 targets are the key to ending the AIDS pandemic. We must continue to build the momentum. On that note, I would like to share with you a letter that I received very recently that is very, very dear to my heart. And it says, Secretary of State, from the Vatican, June 5th, 2015. Dear Dr. Montaner, His Holiness Pope Francis thanks you for informing him of the forthcoming international conference on HIV/AIDS in Vancouver. He sends prayerful greetings to all taking part and expresses his esteem for the work and the dedication it requires. His Holiness is grateful for the many advances made in the prevention and treatment of HIV and AIDS, particularly through highly active antiretroviral therapy and the promotion of treatment as prevention. The lives that have been saved, both through the reduction in the number of new infections and the better health and longer lifespan of those already diagnosed, gives witness to the possibilities for beneficial outcomes when all sectors of society unite in common purpose. He hopes that further efforts may be made to make the fruits of research and medicine available to the world's poorest people, especially orphan children, upon whom this scourge often places the heaviest burden. He likewise prays that all advances in pharmacology, treatment, and research will be matched by a firm commitment to promote the integral development of each person as a beloved child of God. Upon all of you, the Holy Father invokes abundant divine blessings of wisdom and peace. With every good wish, I am, yours sincerely, the Secretary of State. He's a great guy. I love the Pope. If he gets it, why is that so many people? World governments committed to end AIDS at the UN General Assembly Special Session, UNGAS. We must hold them up to their commitment. Treatment as prevention is no longer a pipe dream or a hope. It is scientifically proven, it's a fact, and it's the way forward. Governments must be made accountable to the science, and they should be forced to actually implement what we know it works. Here in British Columbia, we are committed to continue our efforts to end AIDS. And I will let my Minister of Health, the Honorable Terry Lake, to describe for you more in detail the fabulous progress that we have seen over the last many years. All of this we have achieved with the unwavering support of our provincial government, and we're grateful for that. But we have had challenges in Canada, particularly from the federal government in Ottawa. However, we have successfully repelled these attacks. This has been the case in recent times with the attacks of the federal government on Insight, the supervised injection facility here in Vancouver, attacks of the federal government on the city's medicalized heroin program, and attacks of the federal government on initiatives that support commercial sex workers. Rest assured, we will continue to fight back for the dignity and the respect of those that we serve. We, all of us here in this room, must continue to be strong public health advocates. Together we know the science, we know how to scale up the science, and we know how to advocate for it. It is our job to hold governments accountable and to make them and force them to acknowledge the science, implement the policy, and end the AIDS pandemic once and for all. I call on you to sign the Vancouver declaration, the consensus declaration, which I had signed earlier today with all of the plenary speakers here with me today. Chris, I agree with your sentiments wholeheartedly. Vancouver's IAS 2015 will go down in history as the time and place when we draw a line in the sand. And to the many political leaders of the world that have yet to meet their commitments to finance the global AIDS response, including Stephen Harper, I say, you have nowhere left to hide. We have the roadmap to end AIDS. You are either with us or against us. On that note, I will leave you now to reflect on how far we have come with 15 million people on treatment by 2015 and where we aim to go in the future years with this wonderful video put together by the IAS and UNAIDS. Thank you all. Have a great conference and enjoy Vancouver.
I'm living with HIV.
I'm living with HIV.
I'm living with HIV.
Putting 15 million people on treatment by 2015 was a dream. Today, I can say it is a reality. We reach our goal.
When I think back to the Vancouver conference in 1996, I never would have imagined that we would be providing antiretroviral therapy to 15 million people in 2015.
It's less than halfway there, but it is still one of the most remarkable achievements in global health, in the history of global health.
We have saved lives. It's been nothing short of miraculous.
Before Vancouver, there just was a sense of hopelessness, but there was that moment when I looked at my friends and I realized we're going to live.
AIDS changed the world.
At the time of my diagnosis, I was given 2 years to live, and my daughter was 6. I just knew that there was no way that I was prepared to leave a 6-year-old daughter behind.
I found out that my mom was infected when I was 5 or 6 years old.
You were 6.
6.
When I was diagnosed, I got really very sick on AZT, but I just kept taking it because I wanted to live.
Treatment is just a part of who I am.
Treatment works brilliantly, and treatment has changed the face of the epidemic.
In South Africa, as a result of treatment scale-up, we've now seen life expectancy increase almost a decade, which is a change of historic proportions.
We've got to turn off the tap as well as treat those who are already within the pool. And if we do that, I believe we can start to see the epidemic turn on its head. How do we do adolescent health better than we've been doing?
We are definitely denying that adolescents have sex. We are denying that they use drugs. If we want to reach those that we've been leaving behind, then we definitely need the participation of young persons.
Access is really just a huge issue. That's our challenge, is to find those places and to make sure that those people have the same healthcare privileges that we have.
There are continued epidemics, continued spread of HIV. It's men who have sex with men, people who inject drugs, sex workers of all genders, and transgender women.
This new goal for me is 1990-90.
90-90-90 to me says, okay, we build on what we've done, and we do more, and we do it better, we do it smarter.
We have to do better with linking people into care.
How are we going to be creative to actually make treatment available for everyone?
And it is not just a numerical goal. It's about changing completely our paradigm of testing.
This is the time for us to put our collective ideas, innovations, energies, but also our resources into this to push through to the final winning game.
It's about social justice. It's about reaching people we have not been able to reach with our services. It's about human rights.
I am living proudly with HIV.
Please welcome to the stage Ryan and Julie Lewis.
Good evening. Thank you to the International AIDS Society for having us here tonight. And wow, what a milestone to ensure 15 million people worldwide have access to HIV treatment. There's obviously a long way to go, more hard work, more innovation. But I just wanted to pause for a moment and actually acknowledge how substantial that actually is. Put your hands together. Last year in April, my family started the 30-30 Project, kind of in commemorating the fact that my mom had survived for 30 years HIV positive, much longer than my family had expected. And kind of in turn, we seek to build 30 healthcare facilities worldwide in areas that lack healthcare access, and specifically in areas that have high incidence of HIV. I'm very excited that in our first year, we fully funded 5 clinics in 4 countries, including Kenya, Uganda, Malawi, and India.
The 30-30 Project is helping to bring healthcare access to communities that desperately need it. When a new healthcare facility is built for an NGO or government health ministry, not only are general health services expanded, but HIV care and prevention programs become accessible, increasing HIV treatment and stopping new infections. Paul Farmer has often said that healthcare is a human right. He didn't coin the phrase, actually Franklin Roosevelt did. So we have this saying on our 30-30 t-shirts that we're wearing. And to be honest, we get a lot of flack about that. We get comments like, that's impossible, or that's ridiculous. And most common, the question, who will pay for all of that? Well, we know that healthcare as a human right is a lofty goal. And we understand that this idea may never be realized everywhere. But for the people of the Nino district in Malawi, who now have a brand new health clinic that serves 20,000 people, healthcare as a human right is becoming a reality. And for the 2 new clinics in Kenya and the communities that they serve, healthcare as a human right is becoming a reality. And for the hundreds of thousands of people who will have access to healthcare when our next clinics in India and Uganda are built, one breaking ground this month, for these communities, healthcare as a human right is right on the horizon. You know, I've racked my brain for something I could say to you to leave you with tonight, something that would resonate. And what has come to mind is simply this: thank you. Thank you. You know, when we talk about HIV, we often talk about the millions. But really, what we're talking about are many, many individuals. Individuals like myself. Without the HIV medications that I have had the privilege to take for the last 25 years, medicines that many of you worked to create, produce, and distribute, without these drugs, I am sure that today my kids would be calling someone else mom, and my grandkids would be calling another woman grandma. I simply would not be here. You know, you have this giant goal to eradicate HIV, and you have this belief that all HIV-positive people, not just the privileged, should have and deserve to have access to these medications and treatments. Well, we have a lot to do. Nonetheless, you are well on your way to achieving that goal. So tonight, I am sincerely grateful to be at this podium and to be able to say to you all that on behalf of myself and my family and the 15 million people around the globe who now have access to antiretroviral treatment, thank you for what you do, and thank you for what you have accomplished. You have profoundly changed our lives.
Ladies and gentlemen, please welcome to the stage the Executive Director of UNAIDS, Michelle Sidibé.
Thank you. Thank you. Let me start by saying that what we just heard is what characterizes the fight against HIV/AIDS. It is individual stories, it is individual commitment, and it is very touching to hear about the story of Julie and Ryan. I'm so pleased and proud to be here today, back in Vancouver. I want to say thanks to our host, the University of British Columbia. I want to say thanks to the International AIDS Society, and allow me to applaud the International AIDS Society for their incredible convening power. They have been helping us, in fact, to transform our movement, to give a voice to science, to create activism, and make sure that we take stock and we help to reach those people who are in need. And I want you to applaud them and to say thanks to International AIDS Society. I want to thank particularly my friend Julio. I think your contribution is just amazing. You have been able, before all of us, to see that treatment could be a prevention. We didn't hear you, but thanks for helping us to make this evidence possible today. I want to thank you for bringing us here, and thank also Chris Bayer. Thanks Owen Ryan, and also all my friends, Françoise, Jean-François, Michel Kajaskin, and particularly Debbie Burks for joining us today, and Tony Fauci. I could go on, but I want just to say thanks to all of you for being in Vancouver. My friends, let me start by congratulating you for your tireless commitment, work over the last 20 and 30 years. Your activism and your personal commitment help us to translate the world's dreams into reality. You have to remember, people were saying that we were foolish dreamers. They were even saying that we were naive. 15 years ago, in fact, conspiracy of silence was everywhere. And we could see the lack of hope in the eyes of people in Zimbabwe, Zambia. All the hospital beds were full of people sick. And we could not believe that we could help to change. The governments were overwhelmed. The sense of urgency was real, but expectations were also low. It was only, and I said only, in 1996 that the era of HIV treatment truly began when we met in Vancouver. We started under a cloud of skepticism. I want to use this word. We were told that treatment could not be given to poor people. They said it was too costly and people would develop a resistance in resource-poor settings. Only 10,000 people those days in Africa, privileged peoples, were having access to treatment. And no one expected, no one those days, that this situation could change. They were wrong. They were completely wrong. That 10,000 has swelled to 15 million people worldwide today. And I want to say that we should continue to believe that this transformation will be a reality for the people who have not been reached. They said treatment was too complicated. We used to give 18 pills to people every day. Today, it is one pill. Soon, it will be one injection every 6 months. They said treatment was only for the rich. It was far too expensive for poor people. They were saying that the cost would never go down. Some were resigned, even content to let poor people die while rich people could take medicine and survive. They were very wrong. We brought the price down 99% from $10,000 to $100 a year. Time has come for more activism to make a second and third line drugs available and affordable. With the Clinton Foundation, we are ready to start this effort. They told us also that the funding was not there. They were asking us from where all those resources will come. For a long time, we remember we used to have $150 million per year to fight this epidemic. Again, let me tell you, they were wrong. Today, we mobilize $22 billion every year. Each dollar spent has been an investment, not a cost. We have averted 30 million new infections and 8 million deaths in the last 15 years. Cuba has just become the first country to eliminate mother-to-child transmission of HIV. And others could soon follow, like Namibia, Botswana, Swaziland, South Africa, and I could go on with the list. That is what I call transformation. Transformation for those people who were waiting for change. At every turn, we have proven the skeptic wrong. Together, we demonstrate how the AIDS response can change people's lives in every day, from protecting women and girls from violence to educating young people about reproductive health, rights, and sexuality, from decreasing death from HIV and TB through better treatment regimen and drugs, from integrating health services to securing the rights of marginalized communities and protecting key populations, from isolated response to innovative and global partnership. I have just come from Addis Ababa, where the UN Secretary General shared our latest collective achievement with the world. We have reached our goal of 15 by 15, 15 million people on treatment, many months before the deadline of December 2015. It is the first, I said, the first goal set by UN, which has been achieved before the deadline. When we adopted this goal, you remember, just 4 years ago, many people thought it was audacious and out of reach. But the AIDS movement showed the power of international solidarity, community engagement, and evidence and right-based action. We have demonstrated that we can quicken the pace of action and deliver results for people. This meeting in Vancouver should open a new chapter in our global response. 90-90-90 is our opportunity to revolutionize testing, reach millions who are still lacking the diagnostics and treatment, particularly children. It is an opportunity to respond to the live reality of women, mobilize cities by focusing on population and location approach, make viral load suppression a universal priority. 90-90-90 should become a new standard of care. We must issue a Vancouver call, treatment for everyone, everywhere, right now, as a fundamental human right. To not act after the evidence, our friends from Paris and Washington
have been able to share with the world, to not act is morally wrong and ethically unacceptable. We are facing a crisis of conscience. We cannot have this evidence and not go for treatment for all. If we act immediately, the benefits for people will be substantial. We can prevent human deterioration for millions of people. We can prolong life and protect people at risk of new infection. The evidence is clear and compelling. All people living with HIV must have access to ART upon diagnosis. Barriers to access created by bad laws, short-sighted policies, and bias must be confronted and dismantled. A fully funded PEPFAR and Global Fund are a condition sine qua non for our success in the future. A new era of opportunity is dawning, and we must seize it immediately. It is time to reach the 22 million people living with HIV who are not accessing treatment, including the 19 million who do not yet know their status. We know that ARVs alone cannot end AIDS. So a comprehensive, community-driven response is urgent. I have signed the Vancouver Consensus. Please, everyone should sign it. The world must act rapidly in solidarity to drive down HIV incidence, deaths, and long-term costs. We must urgently take the lesson we have learned from 15 by 15 for the final set of treatment targets 90, 90, 90. Treatment for all is a human right. It is not just morally and ethically right, it makes a good business and economic sense. Our returns on investment can be huge if we invest fully now and front load our investment. We can see a return of $17 for every dollar invested. Our return will be even greater if we focus our resources in areas where we have the greatest number of new infections. We have no time to waste. The next 5 years offer just a small window of opportunity to fast track and end AIDS. If we fail to scale up and build on our achievement, the human and financial consequences will be catastrophic. We will see a rebound in the AIDS epidemic that will shock and sadden the world. We will have squandered our collective investment of the last 30 years. Let us together reject this course of history and build on our great achievement to end the AIDS epidemic by 2030. Thank you very much. Merci.
Thank you, Michel, for your passion and for your global perspective. Now, I had mentioned earlier that we here in British Columbia are very proud of the leadership role that we have taken in the fight against HIV/AIDS in this province and beyond. So it's my pleasure now to welcome to the stage our next speaker, the Honourable Terry Lake, British Columbia Minister of Health. Dr. Lake has been a very strong supporter of Dr. Julio Montaner and the work of the BC Centre for Excellence in HIV/AIDS. Most recently, the BC Ministry of Health contributed funding to the newly established Hope to Health Research Clinic in Vancouver's downtown east side, which will continue research in the critical areas of HIV and AIDS, viral hepatitis, and addiction. So we are very proud to have Minister Terry Lake and the BC government support here at the International AIDS Society Conference in Vancouver. Please welcome Minister Terry Lake.
Well, thank you, Gloria. On behalf of our Premier, Christy Clark, the government, and the citizens of British Columbia, welcome to Vancouver on the traditional territory of the Coast Salish First Peoples and the official opening of the IAS 8th Conference on HIV, Pathogenesis, Treatment, and Prevention. It's great to have the IAS back here in Vancouver. Nearly 2 decades ago, in 1996, the Vancouver International AIDS Conference changed the course of the HIV pandemic forever. As you may recall, the theme of the 1996 conference was One World, One Hope. I'm not sure if the participants then realized how fitting that theme was and to what extent it would become a reality. The emerging and exciting evidence of highly active antiretroviral therapy known as HAART generated unprecedented optimism and was formally embraced at the 1996 conference. As many of you know, HAART can lengthen and improve the quality of life of those living with HIV. In fact, sustained HAART treatment can add more than 50 years of quality life for people living with HIV. And we know now that it virtually eliminates HIV transmission. Over the last decade, HAART has given rise to our treatment as prevention strategy. Not only does HAART prevent HIV transmission, it also prevents the disease from progression to AIDS and premature death. A decade ago, my good friend Dr. Julio Montaner, director of the BC Centre for Excellence in HIV/AIDS and local co-chair of the conference, came to us with the proposal to implement treatment as prevention here in British Columbia. After a number of discussions and thorough review of the evidence, we did so. And we have since expanded access to testing, treatment, and support throughout the province. As a result, we have documented impressive gains. AIDS and AIDS-related deaths are down by over 85% in British Columbia. We have virtually eliminated vertical transmission of HIV, and newly diagnosed HIV infections overall are down by 2/3. And as you may know, BC had the worst epidemic in Canada, and today that is no longer the case. In fact, HIV/AIDS-related deaths in BC have decreased by more than 95% since 1996. Treatment as prevention is a cornerstone and a cutting-edge strategy in the global effort to reduce the spread of HIV. It's endorsed by many jurisdictions around the world, including the United States, China, France, Spain, Sierra Leone, Argentina, Panama, and Queensland, Australia. And I'm happy to report that this week, Brazil, who is also implementing treatment as prevention, will sign an official letter of intent with the BC Centre for Excellence in HIV/AIDS. This agreement will give Brazil the benefit of the Centre for Excellence expertise and support as they implement treatment as prevention and also benefit the Centre with shared learning. Treatment as prevention has been a game changer in the efforts against HIV and AIDS, but more work is needed to reach and engage the populations in most need. Services should meet people where they are and when they are ready to engage. That's why the BC Ministry of Health funds the distribution of harm reduction supplies, opioid substitution treatment, and supervised injection services such as Insight here in Vancouver, the first legal supervised injection site in North America. These programs and services have been proven time and time again as necessary and effective parts of a comprehensive strategy to address problematic substance use and to reduce associated harms, such as infections with HIV or other blood-borne pathogens like hepatitis C. BC has successfully developed a strong opioid substitution program, and we continue to be a leader in providing methadone and Suboxone treatment. But we will never truly succeed if we don't effectively battle persistent stigma, discrimination, and intolerance, as well as legal frameworks that are not based on scientific evidence. To facilitate this work, the BC Centre for Excellence in HIV/AIDS, through the kind support of an anonymous donor, has developed an 8,000 square foot clinical research facility in the downtown east side of Vancouver. The Hope to Health Research Clinic is generating state-of-the-art scientific evidence to guide, monitor, and evaluate our public health policy in the areas of HIV, addictions, and viral hepatitis. So I'm very pleased to announce here tonight that the Government of BC will provide the St. Paul's Hospital Foundation with $2 million in funding to help the BC Centre expand the Hope to Health Research Clinic. This will help develop an additional 20,000 square feet to the existing facility. And through science and research collectively, we have made amazing, remarkable advances in HIV. And the Hope to Health Research Centre will continue to make strides because our work is not done. The United Nations AIDS Strategy of 1990 has indicated that ending AIDS will require uninterrupted access to lifelong treatment for tens of millions of people. And the strategy's backbone, of course, is treatment as prevention. To curb HIV and reach the promise of an AIDS-free generation, we must ramp up and fully roll out the 1990s strategy. It can be done, and the people who can make that happen are in this room today. Thank you for what you do. On behalf of all of the people of British Columbia, I wish you a successful conference, and please enjoy our beautiful province. Thank you.
Thank you, Minister Lake, and thanks for leaving $2 million behind. That's always sweet, isn't it? Well, our next speaker, to say the least, is a man of many talents. Evan Adams is a Canadian actor, and he's a medical doctor. A Coast Salish from the Sliammon First Nation near Powell River, British Columbia. He's known internationally for his roles in a number of films, including the American film Smoke Signals. Well, Adams has also worked extensively with First Nations health programs in Canada, including HIV/AIDS. After completing a medical degree and his residency at St. Paul's Hospital, UBC, as chief resident, a Master's of Public Health from Johns Hopkins University, he served as the Deputy Provincial Health Officer with the British Columbia Ministry of Health. Adams was appointed the first ever Aboriginal Health Physician Advisor for the province of British Columbia. He recently became the Chief Medical Officer of the First Nations Health Authority in British Columbia. Ladies and gentlemen, please welcome Evan Adams.
Thank you very much. I'm so very honored to have been invited to say a few words to you about Indigenous people in Canada and in British Columbia. According to the United Nations, there are an estimated 370 million Indigenous people living in over 70 countries worldwide. In the United States, in Canada, Australia, and New Zealand, but also in Panama, Guatemala, Ecuador, Bolivia, Chile, Brazil, in Rwanda and Burundi, the Congo, in India, Bangladesh, Malaysia, Nepal, Papua New Guinea, and in Polynesia, and many, many other countries. And they represent a very rich diversity of cultures, religions, traditions, languages, and histories. And yet they continue to be amongst the world's poorest and most marginalized populations. They are quite simply original peoples who've been moved over by waves of migration. And migration is not a dirty word. It happens in every country of the world. And to move around is quite human. After all, we have legs, we're not barnacles. But Indigenous peoples around the world have been at higher risk and have higher incidences and prevalences of HIV and AIDS because of their social risk at the margins of their original homelands. And of that I would like to speak. I'd like to acknowledge the courage of Indigenous peoples around the world who've been infected with HIV, who have shared their stories with their friends, families, and communities, who have been ostracized, stigmatized, and rejected while giving away their privacy in the name of wanting to prevent the further spread of HIV and to improve access to HIV/AIDS care, treatment, and support, and have challenged their families, leaders, governments, churches, caregivers, and scientists to give them a fair shake. Here in Canada, Indigenous peoples have the worst health, the worst poverty, and the worst housing of any ethnic group in the country. And just like our poverty and our marginalization marks our bodies, it affects our minds and our spirits, our homes, our environments, and opens our bodies to increased incidences of many injuries and diseases, including communicable diseases and including HIV. Here in British Columbia, Indigenous peoples are asking, some say demanding, equity in outcomes with other British Columbians. Equality in HIV outcomes is equality. We ask for equality. But here in British Columbia, the federal government and the provincial governments work with First Nations governance. 203 individual First Nations, almost 200 chiefs, 250,000 people in a tripartite relationship working to improve health services for First Nations in British Columbia by including Aboriginal engagement as a guiding principle in healthcare services. And as with other Indigenous populations in other countries, in British Columbia, First Nations are disproportionately impacted by HIV/AIDS. First Nations in BC are still not retained in care or achieve viral load suppression with the same success as non-Aboriginal populations. People living in rural and remote areas with and at risk for HIV/AIDS could have better access to HIV specialists, to primary health care, to support workers, to peer networks, to information, to harm reduction materials, mental health care, and social supports. Indigenous individuals also have the right to access care, to have respectful interactions without any discrimination with all social and health services. And Indigenous peoples have the right to culturally safe care. Here in British Columbia, 100,000 healthcare workers have committed to Indigenous cultural competency training, and of that we're very proud. The First Nations of BC are firm partners in our healthcare system through inclusion in health governance, the transformation and refresh of our systems to include our wellness perspectives. And this includes HIV care in all health authorities. We are at the table assisting with the rollout of treatment as prevention. The First Nations Health Authority supports treatment as prevention that reaches all communities, regardless of postal codes or whether they live on or off reserves. I acknowledge the key leadership role that Canadian Aboriginal AIDS Network plays working with Indigenous populations and organizations across the country to ensure indigenized HIV/AIDS and hepatitis C information and resources are available to First Nations, Métis, and Inuit communities. We call upon those who can affect change within the Canadian healthcare system to recognize the value of Aboriginal healing practices and to use them in the treatment of Aboriginal patients in collaboration with Aboriginal healers and elders where requested by Aboriginal patients. We call upon the Government of Canada to develop measures to achieve the goals of the United Nations Declaration on the Rights of Indigenous Peoples. We acknowledge the leadership and working relationship of Dr. Montana and the BC Centre of Excellence in HIV/AIDS, and congratulations, Dr. Montana, on your special award from the Canadian Aboriginal AIDS Network this week. We affirm, your blanket was very beautiful, by the way, and we affirm our desire to work with our partners, including the BC Centre for Excellence and the Ministry of Health, to identify barriers and find solutions with the goal of being able to meet the UN AIDS target of 90-90-90. Finally, I wish you an extraordinary conference. In the words of one of our esteemed elders about her life before residential school, she said, we had nothing to do but help the people. In our partnership with BC's health leadership, we constantly ask ourselves, where is the respect and honor between us? And we find it. We wish you, the conference participants, the same, to not just learn and have a good discussion, but to find the respect and honor between you and to help the people. Imot. Thank you.
Evan, thank you very, very much. Well, we are indeed privileged tonight to welcome our next speaker to provide the evening's keynote address, which I think you're going to find very stimulating. Dr. Nora Volkov became director of the National Institute on Drug Abuse, NIDA, at the National Institutes of Health in May of 2003. Now, NIDA supports most of the world's research on the health aspects of drug abuse and addiction. Dr. Volkov's work has been instrumental in demonstrating that drug addiction is a disease of the human brain. As a research psychiatrist and scientist, Dr. Volkov pioneered the use of brain imaging to investigate the toxic effects and addictive properties of abusable drugs. Her studies have documented changes in the dopamine system affecting, among others, the functions of the frontal brain regions involved with motivation, drive, and pleasure in addiction. She has also made important contributions to the neurobiology of obesity, ADHD, and aging. Ladies and gentlemen, please welcome Dr. Nora Volkov.
Good evening. It's an honor for me to be here, coming from the addiction field, which I've devoted all my life to, because it actually recognizes what we've known all along, that drugs are an important contributor to the HIV epidemic. But drugs and addiction are highly stigmatized, and as a result of that, they don't necessarily get the attention that they deserve. The importance of drugs, in particular injection drug use, in the epidemic of HIV was recognized from its inception. And the impact that injection drug use has had on the HIV epidemic has changed through time and geography. Currently, it is estimated that 1 out of 10 new HIV infections are related to injection drug use. And it is also recognized that injection drug use is a very effective way of disseminating the HIV virus. And this is actually illustrated in 2 current outbreaks of HIV associated with injection drug practices in 2 very different settings, Greece and the United States. Greece is among the European countries with the lowest prevalence rates of HIV, and the rates and incidence of HIV among injection drug users have been very low, estimated approximately at 9 to 19 new cases annually between 2000 and 2010. And yet in 2011, they documented a very precipitous rise of 266 new HIV cases in injection drug users that jumped almost to double the next year in 2012. And these cases were the result in 2010 of the closing of the needle and syringe exchange programs that were funded by the government because of budgetary constraints. In the meantime, in the United States, where the rate of HIV in injection drug users have been decreasing for many years and the incidence rates had been very, very low, in a small county in Indiana, Scott County, of 4,200 inhabitants, where there were reported cases of at less than 5 HIV cases associated with injection drug use annually. In January of 2015, this year, since then have reported 173 new cases of HIV on individuals injecting the drug oxymorphone, highlighting the effectiveness of this route of administration. And yet, these 2 outbreaks are not per se reflecting unique situations or environmental conditions. We have similar situations in other areas of the world and in some areas, rural areas in the United States. And these outbreaks should have never had happened. And they should have never had happened because for many years, research has shown that needle and syringe exchange programs are effective interventions to prevent the infection of HIV on injection drug users. And they are effective because injection drug users get infected from the use of contaminated material. Therefore, it's not surprising that they work. What has been much more challenging to understand is what is it that underlies the behavior of the person that's addicted, that will inject these drugs, despite the fact that they don't have clean syringes, despite the fact that they know that they have a very high risk of getting infected with HIV, with hepatitis C, despite the fact that they may know that they have a high risk of dying from overdoses. What drives that behavior that's so difficult to understand? And that's where the science of addiction comes through. And over the past 20, 30 years, very much thanks to the development of imaging technologies that have enabled us to look inside the human brain and to investigate how drugs affect its function, it has become clear that addiction is a disease of the brain, that it is a chronic disease of the brain because the changes produced by drugs are long-lasting and persist months, years after the discontinuation of drug use. But these imaging technologies have also allowed us to investigate which are the areas of the brain that are damaged by drugs. And this slide illustrates that, using a technology that has been used and continues to be used by cardiologists to identify the area within the heart that has been damaged by a myocardial infarct. That same technology can be utilized to identify the area within the brain that has been damaged by drugs. And from these studies, what has emerged is that one of the most sensitive areas to the effects of drugs is our frontal cortex. And it is through our frontal cortex that we are able to make judgments, decisions, and very importantly, once we've made a decision, to carry it through. It is the frontal cortex also in our brains that allows us to exert self-control, to regulate our emotions, to regulate our desires. And this is the area that is damaged by the repeated administrations of drugs. From this knowledge, we have learned to also understand something that's very fundamental to all of our behaviors. On an everyday basis, all of us are exposed to situations where we may want to do something because it promises a reward, but we may think better of not doing it because it may result in negative outcomes. Or we may encounter something that is aversive, yet at the same time we may want to proceed and do it because it promises to have a benefit in the long term. And it is the balance in the brain between the circuit that enables us to exert self-control and make decisions, the frontal cortex, and the areas of our brain that we've described as the limbic brain that enables us to feel emotions, desires. That balance is what will determine our actions. And in a person that's addicted, the repeated use of drugs has damaged the frontal areas of the brain that normally exert that control, while at the same time, the repeated use of drugs enhances the sensitivity of the limbic areas of our brain to emotions, to stress, to frustration, and the brain becomes unbalanced. And on those circumstances, the control systems cannot overpower the strong desires of taking the drug. And this explains it. It explains why a person that's addicted to a drug cannot stop even though they cognitively don't want to do it. They just cannot do it. But also explains why individuals that are addicted to drugs are also at much greater risk of engaging in behaviors, sexually risky behaviors, that increases their likelihood that they're getting infected. The good news is that drug addiction can be treated. And this slide, for example, shows that not only can an individual that is addicted to drugs, if receiving proper treatment, can recover, but that the brain also can recover. It's a slow process, but you can see that recovery of the frontal cortex as a function of the time of since discontinuation of these drugs. Now, the fact that we can treat drug addiction is fundamental for what we're trying to achieve here. And it is fundamental because the treatment of the drug abuser is necessary to ensure that an individual that is a drug user but is also HIV positive will adhere to their medication. And many of the worst outcomes that are reported in individuals addicted to drugs given antiretrovirals reflect the fact that they are not being introduced into a treatment for their substance use disorder, nor are they adhering to their substance use disorder treatment. When you do provide both, the outcomes are not different from those of individuals that are non-addicted to drugs. It is clear that the treatment as prevention is a transformative approach that gives us a very powerful tool to address the problem of HIV, to prevent HIV. And the work at British Columbia has shown the benefits of this, not just in improving outcomes for those that receive the treatment, but it has shown an effect at the population level, indicating a decrease in the new cases of HIV when you expand treatment and you aggressively include engagement of high-risk individuals, injection drug users. But you have to provide an infrastructure that will sustain their adherence to their treatment, which of course implies that you have to provide the treatment for the substance use disorder. In speaking about injection drug use, the main drug responsible for injection practices across the world is heroin. And we're lucky that there are 3 very effective medications for the treatment of opioid addiction, heroin and other opioid medications: methadone, buprenorphine, naltrexone. All of these 3 drugs bind to the mu opioid receptor, which is the receptor that is responsible for the rewarding effects of heroin. Methadone is a full agonist, so that when it binds, it produces a large effect. It requires daily dosing. Buprenorphine is a partial agonist, which means that even if all of the receptors, all of the mu receptors are occupied by buprenorphine, you will never have as potent effect as those of methadone, and it requires daily or every other day dosing. And naltrexone, on the other hand, is an antagonist. So it binds to the receptor, but it has no effect. But by binding to the receptor, it interferes with heroin binding to it, and therefore it interferes with heroin's rewarding effects. All of these 3 drugs have been shown, actually, when implemented, to be beneficial both for prevention and treatment outcomes in HIV. In 1993, in a classical paper by Metzger, he showed that treating heroin abusers with methadone prevented seroconversion 18 months later, and it had a large effect. This was a time when the incidence of HIV was very high in injection drug users. So he was able to show this large effect of methadone. More recent studies at times when the incidence of HIV among injection drug users are much lower have also shown benefits, both for methadone and buprenorphine, in decreasing risky behaviors associated with injection, whether it is the frequency of injection patterns or the sharing of needles. But these medications have also been shown to be beneficial in treatment outcomes of HIV. And these are some examples of the studies that have documented this. For example, treatment with methadone, individuals that are treated with methadone injection drug users are much more likely to initiate antiretroviral therapy earlier on than those that are not being treated with methadone. Similarly, individuals that are being treated with methadone or buprenorphine or naltrexone are much more likely to have achieved 95% adherence to antiretroviral therapy, or to achieve suppression of viremia, or to have better CD4 outcomes. So we have the tools we can treat heroin addiction. We can treat addicted individuals with antiretroviral therapy. So what are the issues? The issues are that we are not implementing medication-assisted therapy for those that could benefit from it, and that we are not providing antiretroviral therapy to addicted individuals, including injection drug users. How bad is the gap? And let me share with you some of the numbers. To your left, you have data from Wolfe et al. That was published in 2010. He selected 5 countries where injection drug use is one of the main drivers of the HIV epidemic. And he measured actually the number of individuals that were given methadone. And you can see from the numbers in red, it is negligible. And in some countries, it's basically 0. In a follow-up study that was published in 2015, this investigator looked at whether there has been improvement in these parameters. And he shows that in certain countries, there have been significant increases in the number of individuals having access to methadone. Most notable, perhaps, Vietnam and China. But other countries, those advances have not materialized. And in the United States, actually, we're also lacking. This study was evaluating the number of specialized treatment programs for substance use disorders in the United States that offer access to medication-assisted treatment, places which are likely to be where injection drug users will end for their treatment. Less than 1/3 of them provided access to medication-assisted treatment. And those that provided medication-assisted treatment will give these medications to less than half of the patients that would have benefited them. So what about the other side of the equation? The treatment of antiretroviral for injection drug users that are HIV positive. And again, this is the data from Wolfe on the same 5 countries. But in blue here, what he's showing is the percentage of individuals that have HIV that are injection drug users. And in red, he shows of the total number of individuals being treated with antiretroviral therapy, what percentage of them corresponds to injection drug users. And you can see that gigantic disparity. Despite the fact, for example, that in Russia more than 80% of the cases of HIV are due to injection drug use, we see a minimal utilization of medication-assisted therapies. And to your right, you have a survey done in the United States that evaluated the clinician's willingness to initiate antiretroviral therapy in patients as a function of their clinical status and their injection practices. And what it shows is that in individuals that are, even if they are occasional injection drug users, but clearly if they are regular injection drug users, clinicians are very unlikely to initiate antiretroviral therapy. And even in those that have less than 200 CD4 counts, less than half of them will initiate antiretroviral therapy if the individual is a regular injection drug user. So what is it that we can do from the perspective of research and as an agency, the National Institute on Drug Abuse? Well, we focus in 2 areas. One of them relates to medications that can improve the adherence of the substance abuse treatment so that we can improve the adherence on the antiretroviral therapy. And there are various strategies that we are funding researchers to follow. Some of them are very low-hanging fruits. Extended release formulations. If you are an injection drug user and you are committed to stop taking drugs and you go into a methadone treatment program, you have to go to the methadone treatment program on a daily basis. And in many countries, the methadone treatment programs are far away. So that's a commitment of hours every single day in order to get your treatment. And also, every single day, you have to battle and fight. Will I go to treatment? Will I go and take the drug? So extended release formulations make sense. And currently, the FDA is evaluating an extended release for buprenorphine that will require 6 months dosing, and for which the phase 3 clinical trials have actually shown superiority as would have been expected from the regular buprenorphine. Another strategy, naltrexone. Many countries, many settings, most notable the criminal justice systems, reject the use of opioid substitution therapies, of opioid agonist medications. So let's work with antagonist medications. They don't have any effect. But antagonist naltrexone requires daily dosing. So what about an extended release? And indeed, the data that you see there was the one that led the FDA to approve the extended release formulation of naltrexone known by the name of Vivitrol, which had a very large effect in sustaining abstinence, and which studies now are ongoing, as the one that is reported over there, to implement it in the criminal justice system. Very simple implementation. At the time of release of the prisoner from jail or prison, you institute Vivitrol, and that significantly improves the likelihood that that individual will be in treatment. In the meantime, we're also funding researchers to develop more transformative technologies like vaccines or immunotherapies against heroin addiction that, if successful, we transform the way that we treat these addictions, and if we succeed, of course, may even be utilized for prevention. But the other area of research that is as important is that of implementation science, because we have the medication-assisted therapies for which already the data has been shown to be beneficial for prevention and treatment of HIV, but they are not being implemented. So we're working with strategies that can expand its utilization on environments where substance abusers, where individuals that take drugs, where injection drug users are likely to end up in. Substance abuse treatments. The healthcare system has devoid for many years of the responsibility that they have to address the screening and treatment of substance use disorder. And in the process, we all have lost of the opportunities of doing interventions that are going to be beneficial for the individual and for the population. So this is an example, again, a very simple intervention. Emergency room. If you're an injection drug user, the likelihood that you end up in the emergency room is much higher than that if you are not. So why not initiate buprenorphine treatment in the emergency room? And this study shows a very significant advantage of initiating buprenorphine. That's as simple as that. Initiate buprenorphine. The physicians are there, know how to give medications. Initiate it, as opposed to refer them to treatment. And that doubles the likelihood that the individual will be in treatment for their substance use disorder. The other example is, well, infectious disease physicians are used to handling extremely complex cocktails of medications. So why not engaging them in also providing with the buprenorphine? And this is an example of such an integration of care, where the infectious disease clinics are involved with providing the buprenorphine as opposed to referring them to treatment. And also, again, this very simple intervention almost doubles the likelihood that the individuals will be in treatment. And similar strategies are now have shown evidence for benefit for implementing medication-assisted therapies in the criminal justice settings. And we're also working with countries where the injection drug use is driving the HIV epidemics to develop tailored interventions that can maximize the likelihood of uptake and sustainability of these interventions in those countries. So where are we and where do we go from here? Clearly, the example of British Columbia in terms of treatment as prevention and highlighting the importance of treatment as prevention in injection drug users, which has been replicated in other cohorts, including the United States, showing that expanding access to antiretroviral therapy while providing with access to treatment for substance use disorders decreases the incidence of HIV and improves the outcomes in those individuals. This, when looked as part of other proven prevention interventions, has given us the tools that I think it was Michelle who was speaking. We actually has provided us a roadmap. We have the tools. We have the tools that are guiding us, that if we implement, can guide us towards that whole goal of the 90-90-90 or the AIDS-free generation. We have a roadmap, we have the tools, and that is extraordinary. And to me, how extraordinary that is to have those tools and why we cannot give them for granted. So I come from the neuroscience field, and I said, if we were to say an Alzheimer's-free generation, we wouldn't know where to start. We wouldn't know even what is that direction that we need to go. That is not the case on HIV. We have a roadmap. Our challenge is the implementation. And in the challenge of implementation, of course, and we've heard, there are structural issues, there are financial issues, but we humans are extraordinary in innovativeness and solving complex problems. And the success of the 15 million individuals receiving antiretroviral therapy is an example of our capacity to bring the resources and do the right thing. But the other major challenge is stigma. Addiction, despite the fact that it's recognized a disease of the brain, despite the fact that we know can be treated, is highly stigmatized. And that stigma comes in the way of the treatment of individuals, as well as the implementation of evidence-based practices that have been shown to prevent HIV. So as we strive forward with these very powerful tools that we currently have, that we need to deploy, we cannot allow for stigma, indifference, or silence to stand in the way of deploying evidence-based prevention and treatment for HIV in drug users. Thanks very much.
Ladies and gentlemen, please welcome back on stage the IAS 2015 conference co-chairs, Chris Beyer and Julio Montaner.
Well, dear colleagues, friends, it's my honor and pleasure to declare the IAS 2015 Conference on Pathogenesis, Treatment, and HIV Prevention officially open.
We wish you all a very productive and enjoyable week. Enjoy Vancouver. Good night.
Thank you. This concludes our opening session.